we'll go on to Dr. Anand Rajendran. He's going to talk to us about art of retinectomies.
Thank you. It's a pleasure to be talking to you about the art of retinectomy. I'd like to thank AIOC for having me here.
Thank you.
So, So, going forward, I'm going to show you a bunch of videos. Yeah. So this is a kind of a prototype case of an inferior detachment with multiple breaks there. And this was a recurrent detachment. And as you can see, the first thing to do is to delineate, to assess the level of the extent of the PVR, and then go with your diathermy across, and you've determined that there's a lot of PVR inferiorly. And it's important to actually do a little diathermy beyond that area where there's PVR. Now putting in tricot, which I think is great to look for residual vitreous, and then going forwards. You also use the Thanos to remove any vitreous and complete the job later with your forceps, remove any residual vitreous there. And just go forward and remove that fibrotic pillar there. It's important to evert the edge to look for any subretinal PVR there, and then take care of that, remove all those fibrotic pillars. And it's important to freshen that edge as we go. You can see the little bit of PVR there. Make sure it's as fresh as a fresh GRT, so that you apply the same principles. And then once you're done with that, then you can put in PFCL. Make sure there's a single bubble. It's important to get that. A single bubble, put it in slow, lower your infusion, or even sometimes cut your infusion. Put in laser, good amount of laser, at least 3 to 4 rows, and then get your PFCL bubble above that edge, and then finally fluid air exchange and silicone oil. So this is another case where, again, a redetachment. There was an inferior broad buckle, and you'll see that in a little while. So here there was a sliver, a tongue of PVR going down posteriorly. So I do what I call a T-shaped retinectomy. So just take care of that little bit with a retinectomy as you go posteriorly, and then do a T-shape. And then you go all around, and make sure you take care of that anterior flap, as you'll see coming up in a bit. And just move the video a little quicker to make things move. And you can see that the anterior flap is going, and the retina is there. And there you see the inferior buckle with the old cryo marks there. And we're putting in laser there. And it helps to have a bit of the retina attached. So that helps too much of torque from distorting the way the retina settles. And you can see putting in laser, and then finally fluid air exchange coming up. And you see a fairly decent result. So that was that. Then we move on to almost a PVR D1 open funnel RD, where the severe PVR all around. So you can see taking care of the pre-retinal PVR and putting in PFCL bubble. And then the peripheral parts are becoming bullous, though there is some amount of stiffness, and then going ahead with the same vitrectomy all around. And you can see taking care of the anterior flap. And this was a patient who could not position post-op prone, so we went in, put in PFC beyond, and then after that, kept him for 5 days like that, and went in with a second stage later. And you can see the laser being put in. And now it's the second stage, and then replacing the PFCL with oil, and it did fairly well. So this is an even more severe case of a closed funnel RD PVR D3, where you see there's a small pupil IOL, and you see that operculum there. So we're opening that, I'm inserting that cutter, and then cutting up to expose that little funnel of the absolute closed funnel RD. And then I'm going to inject PFCL. You see this PFCL going in. And this PFCL, as it goes in, you can see it going in and popping out, and then actually, dissecting and pushing the retina against the wall of the eye. It's very stiff, and you can see it dissecting, and it goes back and forth, and then doing radial excision first, and then anterior circumferential excision, and removing all that stiff PVR there, and then going bimanual because it's very stiff, and then hacking away the left hand with the forceps, right with the scissors, curved scissors. You can see the posterior retina is now attached, well opposed to the wall of the eye, and then going past this, and then freshening the edge there with the cutter there, settling that part, and then removing subretinal membranes, and finally putting some laser after PFCL, topping up PFCL, a little more laser there, and finally So this is an interesting case that I did fairly recently. See, I've already done the anterior wide retinectomy, but there was this big triangular swath of nasal retina PVR. So I had this option of, actually removing that entire area, but there were two pre-existing breaks above and below. So what I did was just connected them, and then there's this blood clots and the PVR all messed up together. So I went now with horizontally across for the H limb, and then this is proving to be really tough. So I've resorted to the scissors, and then I had to excise it with that. You can see the struggle there. And then, evacuated, put in laser under that PFCL bubble. And this was the time the patient had an upshoot of BP, and you'll see a lot of subretinal hemorrhage happening. And with high IOP and, evacuation, little patiently, I was able to get that clot off. You can see the clot off. And then, again, laser all around, and then looks reasonably decent fluid air exchange, and then oil. Now, this is a case, again, I did probably late last year, Coates disease with, again, adult Coates, is tough PVR. And you can see the big triangular swath inferiorly. You can see the subretinal exudates caked below the stiff retina, and just getting that fibrous tissue off now, and then the tough PVD induction using the forceps, trying to get that off and hoping that that will do, but no, I realized that the retina below is too stiff, and I had to do a retinectomy, I had to resort to that, and there you'll see the subretinal exudates and that clot below mixed up with the muck of the PVR, and then evacuating all that. You can see that being everted and removing, and then finally fluid exchange, and then laser all around, and then finally putting in oil. This is another case of FEVR where you'll see something. Just finishing in 1 minute. Yeah. So this you can see the gleaming vitreous and of the exudates, and the neovascularization, and then the tough PVD, and you can see a large horseshoe tear there, and then initially with the forceps, and then hacking away with unimanual, and then putting in PFCL, and you can see the peripheral PVR. This is where air is coming in, so it gives you three advantages. One, it gives you a panoramic view. There's peripheral neovascularization, the little wispy hemorrhage is also removed, and most importantly, allows you to assess the extent of the retinectomy you need to do. So you go ahead with that, and you're also at the same time removing the exudates and getting this in, and then finally putting in laser under that single PFC bubble, and then fluid air exchange, and then finally this settles. Yeah. I also just want to quickly show you that every case does not need
Anand,
large.
please conclude,
Okay.
because we are short of time.
Sure.
The session is going short of time.
Sure. Yeah. So this is just two retinectomies on either side, and you see with just those two retinectomies nasally and temporally, we're able to settle the retina with PFCL, air, and then finally oil. Yeah. Thank you. Thank you.
Thanks, Dr. Anand.